Good morning, everyone. I'd like to welcome all new members and existing members to the first meeting of the Thurrock's Health and Wellbeing Board for this municipal year. Just as a side note, I'd like to actually give thanks to Councillor Arnold for her chairmanship over the last year, as well as to the work of former members, particularly Councillor Diar, Councillor Maldoni, and former Councillor Ralph for their work that they provided and the time last year as well for some of their to improve outcomes for Thurrock residents as board members. Slightly on to housekeeping, just to remind all members that this is a hybrid meeting, the Committee of the Council, and it's being recorded and streamed online for all to see. We have a bit of a full agenda, so again, I've been made aware that we have a flagging system in place, so just like to say that when you've got 2 minutes remaining, you will be flagged and carded down just to make sure we can try and keep to as timely possible in our slots. And a side note, there will be a fire alarm test at 11 AM, so just be mindful of when that does go off. I'm just going to slowly move around. I understand I'm now on to agenda item. Just to say, I've got apologies for absence from Alexander Meekan, Jim Nicholson, Michelle Stapleton and Sheila Murphy in advance of this meeting. Moving on to agenda item 2, I'd just like to say we are at the minutes and action logs. So the minutes and actions arising from February's board meeting, provided on page 5. And as far as I'm aware, there was no actions or decisions for the log for the beginning of the year. And just get acceptance from all members that they are accurate record of the minutes from those present. All content with that? I'll take that as accepted. And then agenda item 3, urgent items of business. I've received no urgent items of business in advance of this meeting. Agenda item 4 for declarations of interest. May I ask any declarations of interest to be made by members? No. Agenda item 5, terms of annual review. The covering report for the terms of reference for annual review can be found on page 17 of today's papers. We have 25 minutes for this item and provide a presentation. I'd like to hand over to Darren Christensen to introduce this report.
Thank you very much, Chair. As the Chair's mentioned, you've got a covering report in your papers, but if I draw your attention to page 21, that really sets out where the changes are. It sets out what the statutory requirements are. We review these on an annual basis in terms of reference to the board. That is an ongoing commitment to the Health and Wellbeing Board, and it reflects the legislation that's been set up as part of the Local Government Act 1972. We have to have one elected member, but we have 4 elected members sitting on board. And then what we've done on the membership there is we will tidy that up, but what it does is it lets you see who the old members were and who the new members are. So we're just changing the membership to reflect the current membership. And then moving on to section 3 on page 23 of your papers, sets out some of the operation of the board. So as the Chair has just mentioned, we've introduced a flagging system to support agenda items remaining on time. And we're going to have a review of the health and wellbeing strategy each month based on one of the domains. And then finally, the functions and the statute, which are on page 25, set out what the subgroups of the Health and Wellbeing Board are. One of those is the Thurrock Integrated Care Alliance, one is the Housing and Planning Advisory Group, and the Brighter Future Partnership, which oversees the Brighter Future Strategy. I won't dwell on this too long because they are just standard amendments to the terms of reference, so I can open that up to the floor, Chair.
Does any member have any questions about the terms of reference? No. Can I just make one note, Darren? I know we were talking about moving over to Thursday meetings. The Health and Wellbeing Board, on page 23, it's still referenced to Friday. I don't know if that's been can that be updated or been updated?
I'll make that updated.
Thank you.
Thank you.
Right. So it's can I get a recommendation to all agree the changes to the terms of reference as outlined in the report? We all content?
Yep.
Thank you. Agenda item 6. We have the joint forward plan for Mid and South Essex. The covering report and supporting documents are both found on page 27, and we have 25 minutes for this item. May I introduce Jeff Banks in order to introduce the report?
Hello, thank you, Chair. Thank you very much. We're really pleased to be here today to present the joint forward plan for the Mid and South Essex Integrated Care Board. Just by way of introduction, so my name is Jeff Banks and I'm the Director of Strategic Partnerships for the Integrated Care System, and I've been really pleased to have had the opportunity to attend this meeting a number of times and to work quite closely with colleagues from Thurrock on our developing agenda. The Integrated Care System came into being in July 2022 under the terms of the Health and Care Act 2022. It comprises two boards: the Integrated Care Board, which is a statutory body responsible for NHS services, and the Integrated Care Partnership, which brings together the much wider set of contributors who are wanting to work together to improve health and care outcomes for our residents. The Integrated Care Partnership developed an integrated care strategy which was approved by this Health and Wellbeing Board earlier in the year, and this describes our shared ambitions for health and care in Mid and South Essex. Today, the ICB is presenting the Joint Forward Plan, which outlines how the NHS will discharge its duties in meeting national priorities and the local integrated care strategy agenda. The Joint Forward Plan is presented in three parts, with parts 1 and 2 outlining our vision and our key priorities, and part 3 provides in some detail how we will seek to enact these priorities and put these into practice. In part 1, you'll see, members, that you have an executive summary. It gives an outline of how the NHS will take forward the integrated care strategy, taking into account local health and wellbeing board strategies, such as your own, in our 3 upper-tier local authorities, along with the strategic ambitions of the NHS and wider partners. Part 2 describes the underpinning approach which we will take to deliver on our collective ambition to improve population health and reduce health inequalities. These 2 parts, Chair, are the parts which we would ask members to particularly focus on and where we're very keen to hear members' views about the extent to which the plan reflects the current challenges and the ambitions of the Thurrock Health and Wellbeing Board and your own strategies. The part 3 that you've got, which is the set of appendices, gives a high-level delivery plan for each of the long-term aims that we've committed ourselves to, and shows how we will seek to discharge our statutory functions within the NHS. These will, of course, Chair, develop over time in partnership with you as our key strategic partner here and responsible for adult and children's care, and also in partnership with other organisations and agencies in and around Thurrock. And also, Chair, that part 3 will also develop over time with our continued commitment to ongoing engagement with residents and wider stakeholders. We've, as you'll see in the paper, Chair, we've undertaken extensive engagement with partners and residents, and we are fairly confident that the Health and Wellbeing Board will see the concerns and interests of Thurrock Council and local partners here in Thurrock represented in the plan. Every section in the part 3 and details quote what residents have told us, so you'll see that we reflect the views of residents throughout the strategy, and we've worked very hard to ensure that residents' voices and their concerns are our concerns. We've worked very closely with partners across the health and care system in developing our plans, and we're very grateful for your support and colleagues from here in Thurrock. The Integrated Care Project, Chair, has at its heart the development of a closer working relationship by partners working across health and care. We'll continue to develop and refine the Joint Forward Plan with you over the next 5 years. The plan will also be updated annually, taking into account changes in the circumstances and in response to our performance and progress in meeting the targets together. In developing our Joint Forward Plan, we're required to bring a draft to each Health and Wellbeing Board in the area we serve, and to receive from you, Chair, an opinion on the extent to which the Joint Forward Plan takes into account and aligns with the strategies and priorities of Thurrock Health and Wellbeing Board. This opinion, Chair, will be included in the final published version of the document. We'd be very grateful for members' views, and I'll be very pleased to answer any questions. And I also have Margaret Allen with me as well, who will also contribute to supporting any questions that you may have. We hope then, Chair, that you will feel confident that on behalf of the board you can issue us with a formal opinion letter, and we'd be really grateful and if this could be received in some pace because we have to publish the final plan by the end of this month. But I'd be very pleased to support you with that. But we'd be pleased to take any questions.
Thank you, Jeff. Just to put on record, really, from me straight away, from reading through, it's really quite a comprehensive joint plan that we've got together there, coming down from the ICB. Especially, I'm quite happy just how our health and wellbeing strategy has been brought really into core of that. So we're focusing about health inequalities. We're talking about avoiding avoidable mortality. I think it's really quite good. It's quite clear going through the joint ambition together to say this is one of the key things we really need to make sure we level the playing field. And at the same time, it's really looking at transformation across the whole system, especially seeing how we're looking at human learning systems perhaps and how that's featured in, and just as much as seeing how we're looking at population health management approach and just really how what our public health team in Thurrock do day to day, seeing that their work really does feed into that. So I just wanted to put on record really immediately my thoughts before I go out. I just want to see if there are any members that wish to make any comment. Oh, Ian.
You've articulated actually quite beautifully what I've written down and was about to say, Councillor Cockshaw, but I'm going to say it anyway. So it's what I actually said at the ICB board meeting as well. So I've worked either within or very closely with the NHS for, I think, coming up for 28 years now. I've never in those 28 years seen a plan that has such a strong focus on prevention and inequality, and I think that's to be hugely welcomed. What's also really pleasing, I think, about this is there's a real clear commitment to subsidiarity and to the alliances and to devolving power downwards, and it's clear from the plan just how much of the Thurrock ambition is reflected within it. So I think that's hugely welcome, and I think Thurrock's incredibly grateful for that. The delivery mechanism for this in terms of the finance is clearly largely going to be the Better Care Fund, and we need to ensure that our collective ambitions are reflected very strongly in the BCF moving forward. And then finally, I'm going to embarrass him, I'd like to pay tribute to Jeff himself. I think since you've started, Jeff, there's been a really clear and demonstrable sea change in strong partnership working between the centre and the alliances. And so, yeah, on behalf of Thurrock, I'd like to really thank you for all of your efforts and your ongoing strong commitment to partnership working with us.
Any other member have a comment? Councillor Rigby.
Thank you, Chair. Thank you for your report as well. Yes, sort of moving on and talking a bit about the inequalities, it's quite staggering how high the obesity and smoking rates are across Thurrock and Basildon that are causing a lot of, avoidable deaths through sort of diabetes, cardiovascular disease. It's going to be a long time to sort of try and reverse those sort of changes or help to improve them. What sort of is your sort of real, I suppose, sort of more likely sort of time span to try and reduce these inequalities to a sort of proper measure, really?
Thank you. That's a really good question. And thank you for your kind comments, Chair, and Ian. I really appreciate that. If I just pick up a little bit on that point, and then I'll move on to your specific question, and perhaps Margaret, I'll bring her in to give some specific response to the work we're planning here in Thurrock, in our alliance here. Sorry? Oh, Joe, sorry. Oh, thank Joe as well. Sorry, yes, absolutely. But yes, just to say that the commitment to addressing the health inequalities is actually front and centre across our system work. And colleagues will be aware that before our integrated care system was a year old, government commissioned an independent piece of work to review the work of the integrated care systems, which was undertaken by Patricia Hewitt. And that review is very readable, and I think it's well worth members taking a look at it, because it really does reinforce that point that we need to move, as Ian says, away from being a health service to being a wellness service, one which is actually really focused on preventing, early intervention, early diagnosis, and ensuring that we tackle the wider determinants of health, which in many instances cause those negative outcomes that for those as councillors you've demonstrated here. I think Margaret perhaps could address the point about the specific work we're looking at doing around the obesity, smoking, and those specific areas of focus here, because she's our Deputy Alliance Director, so might give a good account to that. Margaret's on screen, so I don't know if she is able to come in.
Just before, I'm just going to bring Jo in. I think Jo's got a few comments just about specifically for Thurrock, if that's all right.
Yeah, thank you, Chair. I'll be talking more about specifically what we're doing around tobacco and obesity in the final item on this agenda, but just in terms of that sort of timescale question, we've done a lot of work around tobacco and have seen actually smoking rates fall substantially pre-pandemic to post-pandemic. Our smoking cessation team were extremely busy, virtually supporting people to stop smoking during the pandemic, and that is reflected in our current statistics. So we're now slightly below England average for smoking rates, which is a real improvement, but we've still got a long way to go. There's a national ambition to reduce smoking to 5% of the population by 2030. We're currently at 12.6%, so there's quite a long way to go. And the fewer people who smoke, those people will generally find it harder to give up smoking, so it's going to be more difficult the lower we get, but we're working quite hard, and I will tell you in the final item something about that. In terms of obesity, I think this is a really difficult one. It's a really complex and multifactorial condition. We do a lot of work locally, which again I'll talk about later in the meeting, but a lot of the drivers of obesity are around national policy. That's policy in relation to, spatial planning, food policy. We know that the National Food Czar resigned last year around controversy around implementation of food policy at the national level. So it's quite hard for us to deal with all the levers locally, but we do have a lot of actions in place, but I think that one is going to be a much slower impact, and what we need to be looking at is reversing the increases is our initial target, I think.
Apologies, do apologise, colleagues online can't quite follow exactly what the proceedings of the meeting are. We're just trying to have a look and see what we can do. So if you can just bear with us and see if we can get it working. Just while we try and do this, we'll suspend the live stream for 5 minutes to give service a chance to see if we can get it working. Responses from Councillor Rigby. I don't know if you can jump in if that's fine.
Thank you. I didn't hear anything earlier. I've no idea what the question was.
Oh, Councillor Rigby, do you mind just repeating question first and we'll go back?
Hello there. Yes, so I was asking about the health inequalities relating to obesity and smoking and the time frame the anticipated time frame to get down to realistic, anticipated levels to help with the diseases that are that could be prevented by reducing these levels.
Can I just ask if Joe Broadbent was able to give any answer to that so that I can maybe add to it?
Yes, no, Joe did give an answer, Thurrock-based answer on that one.
I basically said we were working towards the 2030 5% smoking target and had plans in place to do that, but the obesity reduction was a lot more complex and would probably be a much more long-term approach.
Yeah, I would agree with that, Joe. Certainly we have various initiatives that are happening in Thurrock. There is a pilot, particularly in Stamford-le-Hope PCN area, that is looking at trying to identify significant numbers of people who are overweight or obese, and are actually under the prevention agenda trying to work with them in a slightly different way, added to which Thurrock also benefits from what's called Tier 2 and Tier 3 weight management services. And one of the things that I commissioned when I was responsible for the weight management services across Mid and South Essex was a severe binge eating behaviour service. And the reason that I commissioned that, and this is open to Thurrock residents as well as other residents across the rest of South Essex, this isn't commissioned for Mid Essex. The reason I did that was that there's a dropout rate of anything around 30% when people are referred onto Tier 3 weight management programmes. And doing some work with our weight management providers, we identified that an awful lot of that 30% of people that drop out because they have severe binge eating behaviours. And if you don't address that, a weight management programme will never work. So they now have a pre-Tier 3 12-week programme that addresses the severe binge eating behaviours. And we have seen some incredible results from that, both in terms of the dropout rate and the number of people who are gaining an increase in loss of weight and maintaining it for longer. If the Health and Wellbeing Board would like some facts and figures on that, I can certainly get some to you for the next meeting.
Yeah, no, I think that members would actually quite appreciate it if you could get some facts and bring to the board.
Absolutely.
Really appreciated.
Yeah, no problem.
Jeff, do you want to come back? Yeah.
Thank you, Chair. Thank you for that, Margaret, and also Joe. And you'll notice in the Joint Forward Plan there's some very specific actions that we're planning around both smoking cessation and healthy weight. It's an interesting point that you raise, Councillor, because these are two of the areas where they are so complex in how we tackle them that, in fact, the only way to effectively do it is through a very concerted effort of a range of different partners coming together, because there's no one magic bullet which can tackle those things. And many of our colleagues, Joe, I'm sure you'll reflect, working in public health, will say that these are the classic example of the wicked problem, the things that we've been trying to tackle for many years. And what the Joint Forward Plan commits us to is ensuring that we make the best effort to work connectively and collaboratively with a range of partners across that, because it is one of those things where we simply won't make progress alone as an NHS system, because the causes and the contributory factors are very much in that wider determinants of health arena. And as you all know, the NHS, the quality of care and the availability of care only really accounts for a small percentage of the contributory factors for people having the healthy long lives that we want them to have. So I think you'll see in the plan, Councillor, a real commitment to that multi-agency partnership working. And particularly in Thurrock, we've got a fantastic track record of working really hand in glove with the public health teams, particularly around those population health management agendas. So we're really grateful for that support.
Liz, before I come in, Rita, do you want to just come in and add a bit more?
I thought it would be helpful if I just demonstrate in terms of what that looks like from a delivery perspective. So over at Corringham Integrated Medical and Wellbeing Centre, we actually have, as Margaret and Jo has referenced, we actually have something that's defined as a Thurrock Healthier Futures clinic. But actually it's much broader than a clinic. If you actually come along to the site, and the way we're moving more and more forward towards integrated care is on that site you will meet with both the clinicians but also people that are responsible for those wider determinants of health, and particularly around social determinants, housing determinants. As Jo has referenced, when it comes to obesity and an individual being in a position where they may be overweight, it may be up to about 160 odd variables that could be affecting someone's actual management of their health. So absolutely, when we get to the higher levels and tiers, weight management programs specifically around diet, food, nutrition is helpful and has good outcomes, as Margaret has alluded to. But actually we want to get in early. So the Thurrock Healthier Futures Clinic actually allows us to work with individuals. So we have both clinicians, dietitians and other professionals together with health coaches. And those health coaches then support individuals with really good conversations about what potentially could be the determinants, and have basically the skills, but also will be trained in appreciative inquiry to actually support some of those really strong conversations about what's working, what else is going on for that individual. Those markers could be around relationships, housing, debt, access to food, and personal wealth. And that's where we want to get to early on. Within the building and within our communities across the 4 integrated neighbourhood teams, locality teams, we want to bring those individuals together, those professionals that can support some of those conversations and get in early. At Corringham Centre, we're very lucky and fortunate because we have housing colleagues, we have community-led supports, we have our social workers on hand to start having some of those conversations. So we're using the human learning system approach, and we are evaluating what the impact of that early intervention, early support and good conversations will be.
Might I?
Before I do, Councillor Rigby, do you have anything to add quickly, just in case, or before?
Sorry, thank you, Chair. Just a quick comment. It's more a comment, really, but I was interested to hear about the binge eating issue from Margaret, because really that then, as you say, it's multifactorial. That's a mental health disease issue, isn't it? So it is really a big, complex area. But yes, thank you for all you're doing and for your help. Thank you.
Chair, might I just come in to add one final point on the weight management and the obesity issue?
Yeah, of course.
Thank you. Just to say that historically, for Thurrock, at Tier 3, 100 people have been funded each year. That's a drop in the ocean compared to the rates of obesity right across Mid and South Essex. However, over the last 2 years, NHS England has been incentivising GPs to make referrals both to Tier 2 services, and the numbers for Thurrock have gone up from 100 people per year completing the 12-month course to nearly 500 people a year. So we are actually making some more significant inroads at that level. But also just to say that there are plans being drawn up at the moment right across Mid and South Essex, and Thurrock Council officers are colleagues within this working party to radically alter the offer for weight management around reducing obesity and overweight right across Mid and South Essex. That work is ongoing at the moment. We are anticipating that we will collectively be in a position to award a new contract for a new offer by April of 2024. So I can certainly bring some more details around that to the next Health and Wellbeing Board if you'd like that.
I think members would bring Michelle in as well, just quickly.
Thank you, colleagues. I mean, looking at the report, the other area that's key for us, of course, is our Year 6 students. 40% of Year 6 students are overweight. I mean, that really is, you know, another shocking statistic, isn't it? And I guess I'm hearing an awful lot about adult weight management, and I can absolutely see the importance of the family, so I can recognise that. But I guess for me, it's about what are we doing to encourage more healthy eating habits for our children. You know, year 6 is a 10-year-old's coming up to 11. If they're 40% are overweight, then the likelihood is that's going to follow through, isn't it? So my question's that, please. Thank you.
Joe, do you want to?
Yeah, just on that, so we have a whole systems obesity strategy, and it's whole system for a reason, because as we've, I think, adequately demonstrated, it's very complex and it's multifactorial. So in terms of a lot of the actions within that strategy, which are things like looking at the food environment, the built and green environment, promoting physical activity, these are kind of all age actions that will impact across the community. And we're doing things like working with the developing local plan to ensure that things like access to active play it is built into future planning thinking in the borough. In terms of supporting families and children where children are already overweight, and you're right, the latest figures are 40% year 6s overweight or obese, and that was gone up substantially during the COVID pandemic. I think successive lockdowns and the closure of schools, the cessation of so much active play and out of school sport, I think has probably had a real impact on our local children. So we have got an offer of support for families because we need to take a whole family approach to addressing this. It can be quite a sensitive issue for families, so we address this in a sensitive manner. So that service is in place. We've got a child weight management task force that we're setting up across Thurrock, because our GPs, quite rightly, are very keen to help support, refer into these services. But the long-term plan is for us to embed children and family weight management services within our 0 to 19 public health services. We're recommissioning those over the next 15 months, and we'll have a new service in place with a new service specification by September 2024. And this support for children and families and weight management will be a core part of that. We're going to build it in, so we've got some longevity there.
Oh, Jeff.
A very good question again. You'll see in the joint forward plan there's a real commitment to a number of key priority areas around children and young people, and particularly there's a focus on children's mental health, eating disorders, and also SEND, working with children and young people with learning disabilities, special education needs, etc. They're very much key focuses for us, but you'll be reassured, I hope, to know that the Integrated Care Partnership has as one of its 4 key priorities babies, children and young people, and there are significant efforts to make sure that we reach out and engage more with schools as active partners in the health and care agenda across the wider system, and that work is ongoing. We need to develop stronger links, and I'm very pleased myself to have had positive conversations with our education leaders at all 3 local authorities, including those working with children who are electively home educated or do not attend mainstream schools, to make sure that we reach out to those, because very often the way we deliver those healthy schools messages is with children who are in school, and we lean into our education partnerships to do that work, but we need to also be mindful of those children who are home educated for whatever reasons. And to make sure we're reaching out with those messages as well. We have good connections with the Healthy Schools programme, and we want to develop that work further in the future. So it's a point of interest not only for the NHS in terms of the joint forward plan, but also the wider Integrated Care Partnership.
Yes.
Thank you, Chair. Just following on really from what Michelle was saying, and Jeff, locally there is a big issue here with feeding or food for young people, especially when families at the moment hitting real hardship with the cost of living are living from food banks, and that isn't always the most healthiest of foods, but it's food nonetheless. And their access to fresh fruit and vegetables and things like that is really limited. And even if you have those conversations with them, the amount of money they have to top up their food bank parcels, they're just buying the 2 for 1 and 3 for 1 of just instant meals that you put in a microwave. So I think that the children's element of it definitely needs a really big look. The breakfast clubs that schools run tend to be costed for those, there's a cost to it for the children that need to be dropped off before mum goes to work. So that although they get a fresh option for a breakfast there, or a healthy one, it is only for those parents that can pay for that club. So there is some issues out there about looking how do we support those families to access healthier foods. Thank you.
Does any other member have any comments or questions? Councillor Rigby?
Thank you, Chair. Moving on from the children's, is the service at Corringham available to children, or is it adults only directed?
It's for adults.
If all members are content, we'll move on. Oh, sorry about that. If all members are content, we'll move on to the recommendation that we acknowledge the receipt of the draft joint forward plan produced by MSE and confirm appropriately it considers and aligns to the strategies and priorities of the Thurrock Health and Wellbeing Board. All members in agreement?
Agreed.
Great.
Sorry, just one final question. Do you need something formally in writing from this board to record that? Is the minute sufficient? Would you like a letter? I'm aware Southend did something a little bit more formally. If you could you just let us know what would be most helpful to you, Chair?
Thank you. I'm happy to chat to colleagues with that, but ideally, Chair, a letter at the earliest opportunity would be gratefully received. And in addition to noting the recommendation that members have agreed here, if you're able to add some of the flavour of the comments that have come from the meeting, that would be incredibly helpful. And I'd be pleased to support officers in drafting that letter, or anything I can do to help. Please do let me know.
Thank you. We're working to make sure you receive that in time. Moving on, agenda item 7, joint domestic violence and abuse in context of sex and gender, briefing note. This was requested as a consideration of December's board meeting on Goal 5C, which focuses on priorities of people who have and who are experiencing domestic abuse or sexual violence or abuse. Briefing note can be found on page 259 of your papers. We've got 10 minutes from this, and I've got Evelina, who's the chair of the Violence Against Women and Girls Board, to introduce this item. Thank you.
Thank you, Chair. Good afternoon, all. So you have got a briefing note in front of you that in particularly addresses the point about the provision for male survivors of domestic abuse. We provided information in relation to the last calendar year, January to December, and it really is in regards to how we're addressing Goal 5.C in the overall health and wellbeing strategy, and it sort of addresses the questions raised during that meeting. We put a little bit about the understanding of the national trends in data, and you can see the sort of prevalence levels there, and sort of then breaking it down into years and so all of that comes with it. What we are absolutely saying is, which was the point that was put to myself during that meeting, is how we address the support for male survivors. And I present to you at page 263 a sort of a bit of a visual aid to show all of the elements of support that we've got. Within my team, we've got housing safeguarding team. They, whilst called housing, they actually serve the entire borough, all of the population, and they are absolutely a key part. They've got a key part in discharging that duty. We do have a male worker on that team as well, just in case there was that was more comfortable for those coming to us for help. There is also a team of domestic abuse advisors and domestic violence advisors, the IDVAS, which is a more sort of a prescribed role, and then all of the partnership that we work with, and everything is sort of noted there. Overall, I won't necessarily dwell anymore on the report, just key findings. In terms of the males that are experiencing domestic abuse, they absolutely can access support through the various routes that you've got there. Support is really survivor-led, so we're not there to say what is the right type of support for you. We will work with the survivor and take the lead from them, what are their specific needs and wants. And again, we can't necessarily force and wouldn't ever force support if the survivor doesn't want it. We've actually had, and you've got case studies later in the briefing note, we've had some sort of individuals declining support, which again, we just take people as they come. We don't necessarily, there was a request about partnership data, we don't have exact access to that data. But if there is anything, if you've got any questions on CIVIS that is not Thurrock commissioned, we can obviously ask the agency to reply to that request, but it's not within our control. I stop there if there are any questions available. Thank you.
Thank you. Councillor Shinnick.
Thank you for your report, Evelina. Just as being a novice to all this, what would be the best route for someone to go down to report this? You know, i.e. I'm a councillor, and if I had anybody come to me, what would be my best route to report this?
So the best gateway for any such related matters is the housing safeguarding team. So that really, if you go via members' inquiries and ask for housing safeguarding team, it will get to the right officer.
Thank you. Has any other member got any comments? Councillor Rigby.
Thank you, Chair, and thank you, Evelina, for your report. I was quite surprised by the number of males that have been reporting violence abuse, but then the follow-ups are really, really quite low, so that seems to be quite a big gap. Would you say that on the whole, the abuse that men experience isn't as extreme as female, or is it just their approach is different, or just multifactorial on that difference there?
As we sit and debate that during the meetings of the Violence Against Women and Girls Board, as well as the Community Safety Partnership, there is an absolute acknowledgement that males don't necessarily follow the same route for reporting as females do. There is a stigma attached to it. There is something that those males just simply don't want to talk about it, and there is a lot more work needed at the cross-societal level to actually change that perception. So I think that is really the starting point. And then it is also acknowledged that there is therefore underreporting, but it's that change over time that we can influence to actually get males to report more. And I think that the second bit of it is, as I mentioned before, it is led by the survivor. So if they don't want the support, even after the report, if they don't want support, then none will be provided. Or if it's more about signposting and that's all they want, then that's all that they will be provided with. And I think lastly, when we look at sort of female survivors, as a result of the statistics, there is also a lot more sort of information about the support available out there. So we know that what we see here is the reported information, but there are also support networks, community groups, third sector organisations where some of the female survivors go direct and don't actually even appear on the stats. Males don't necessarily have that mechanism. Thank you.
Thank you.
I do see one hand up on Teams. I do apologise. My eyesight is quite bad, so I can't quite see the name. I do apologise.
That's okay. It's Jenny Barnett, so I'm Chief Superintendent for West Essex. It would be remiss of me, of course, not to mention to the councillor that if somebody does come to you with a complaint around domestic abuse or domestic violence, that it should be reported to us. We do have specialist domestic abuse investigation teams, and we also have what we call domestic abuse problem solving teams. They have links into the IDVAS and into the local authority. And those teams are specifically designed to keep victims on board throughout a process, but they're also designed to get the best outcome for the victim, which may not be going through the criminal justice system if that's not what they want. So we do look at all possible outcomes, and we do work with local authorities to make sure they get what they need in terms of being safeguarded on a continuous basis. So it isn't just a case of it being reported and they would be seen by any officer. They would actually be seen by a specialist trained officer, and those teams are established specifically for that purpose. And we have supported a number of obviously a number of male victims and survivors.
Thank you. Thank you, Jenny. Has any other member got any other questions? No? We'll move on to the recommendation then quickly. Just say that it's recommended members note and have commented on the contents of the briefing note. Thank you, Evelina, for the report. Agenda item 8, the health and wellbeing strategy in focus. So this will be an overview. This agenda item is in two parts. So primarily give members an overview of the health and wellbeing strategy, and the summary is provided in the covering report on page 267. So, and then once we've gone through the overview, we'll go into the second focus of part of looking at the reporting back of how Domain 1 over the last year for healthier for longer, and the supporting material for this part is on page 271. With 50 minutes for this item allotted, and I'll pass over to Dr. Joe Broadbent to present.
Thank you, Chair. I'm just going to share... Darren's done it. So we've got, for the benefit of new members and our new chair, I thought it would be helpful before we got into the detail of the first domain of the health and wellbeing strategy to just give an overview of the whole strategy and how we develop the strategy. So as you can see from this first slide, the theme of the strategy is levelling the playing field in Thurrock, and this really reflects that we have a number of enduring inequalities within Thurrock. We have an 8-year life expectancy gap, which is a large life expectancy gap in a population of only 175,000 people. So that's the gap in life expectancy between the most affluent groups in the community and the least affluent groups. We also see big differences in healthy life expectancy. So that's how long someone can expect to live in good health. And for women living in the most deprived circumstances in Thurrock, they can expect to live around 20 years in poor health. So that's 20 years of an already lower life expectancy. So we do have some really enduring inequalities. To develop the strategy, we looked at areas where there was either a key inequality and a gap in service or support that we felt wasn't in place to address that inequality, or we looked at gaps in the wider determinants of health and where they weren't level on the playing field across the whole community. So we have 6 domains in our health and wellbeing strategy that cover a very broad base, but the strategy doesn't have comprehensive actions for every single aspect of all of these. It's about where we can make the biggest difference to inequalities and levelling the playing field. So if you just go on to the next slide, Darren, sorry, the one with the Robert Wood Johnson model, the 4 circles. To develop, could you go to the previous one? Sorry. To develop the strategy, I'll just say we worked very closely with professional leads and stakeholders with an interest in all 6 of the domains. And we asked those groups to identify areas for inclusion in the strategy where we could address inequalities. We drafted then some goals that we thought would be helpful to include in the strategy. And then Healthwatch did a very comprehensive public engagement process for us. I think in total, across the variety of engagements that we did with various groups and with our Healthwatch colleagues going out and about, had around 1,300 different comments on the strategy. And we amended the goals that we were proposing based on that feedback. And our Healthwatch colleagues were absolutely fantastic partners in developing this strategy, and we could not have done it without them. But it enabled us to really reflect the views of residents in the strategy. So an example of that is we hadn't included climate change specifically, but residents felt that that was something that should be mentioned, so we consequently included that. So the 6 domains of the health and wellbeing strategy are focused around those areas. Sorry, Darren, can you go back to the one with the 4 circles? Where there's a strong evidence base around what determines our health and wellbeing. Access to health services is one, a comprehensive access to support around health behaviours. So we've already been talking about obesity and smoking and support to manage those health behaviours. But actually the really key area that has the biggest impact is that pink circle that has just sped past on the screen, is around wider determinants of health. Stop! So it's these wider determinants of health, the built environment, but particularly those socioeconomic factors, are the things that make a real difference. So as Kim was just saying about access to healthy food, this is related to the socioeconomic status of the family, which is related to the educational opportunities that both adults and children have, access to meaningful employment, etc. So that's why we've taken such a broad-based approach to our health and wellbeing strategy, because we won't make the step change that we need to make if we just focus on services for health and well-being. So if we can now move on, sorry Darren. So the next slide just illustrates how this linked to the Council's priorities of people, place and prosperity. The health and wellbeing strategy being one of the 3 key strategies for the Council and is the key people strategy that we have. The local plan is of course our key place strategy, and the backing Thurrock economic growth strategy, the prosperity strategy. But what we've tried to do is link actions into all 3 of those strategies, and we've kind of colour-coded them. So the green domains that you'll see in a moment are around individuals and supporting people, the blue around developing place, and yellow around economic growth and opportunities broadly. So if we move on then, thanks Darren. We can probably zoom past that one. I've just described that, I think. So just this slide illustrates how a number of the health and care strategies we have in the Council fit together. So the health and wellbeing strategy, as I said, is the key people's wellbeing strategy for the Council, but we have a number of other strategies that sit under that. We have the Brighter Futures Children Young People strategy, the Better Care Together Thurrock health and care strategy for adults, and then a range of other strategies such as the housing strategy, homelessness strategy, the whole systems obesity strategy that we've talked about. And these all feed up into the high-level goals of the health and wellbeing strategy. So that's kind of how it fits together. So I'm just briefly now going to go through the 6 domains. I'll be very quick. The first one I'm going to go through in a minute in a bit more detail, so I won't say much about this now, but this is essentially about how we support people to stay healthier for longer. Domain 2 is around strengthening communities. This is very much based on the collaborative communities framework that we have in Thurrock, and this domain is led by the Stronger Together Thurrock Partnership. And the goals under this domain are very much about engagement with residents, empowering residents, and pursuing the equality ambition for the Council. Domain 3 is a high-level summary, essentially, of the Better Care Together Thurrock Adults Health and Care strategy. So all the activity to deliver these goals for Domain 3 essentially sit in that strategy, and there's a lot more detail in that strategy. As has already been mentioned today, there's a human learning systems approach that is threaded through that strategy, which essentially means us working with individuals and putting them at the heart of the design of support and services for them, and having a bespoke and individualised approach. So goal A, C and D in this domain essentially are about different aspects of that, putting the individual at the heart, joined up working across our workforce, and how we essentially transform services and commission in a different way. Goal B is around primary care, and I just wanted to flag that one to you. This is another one that very much links with the feedback we got from residents. One of the key pieces of feedback we got was concern about access to primary care and access to high quality care within the community. So there's a whole raft of activity going on here, for example, improving telephony systems to improve accessibility to primary care. So that was very much, again, linked to resident feedback. Domain 4 is around opportunity for all. So this is yellow coloured, links with our Backing Thurrock economic strategy, and it essentially promotes opportunities, educational opportunities for children, young people and adults. It links to the Backing Thurrock goals, and particularly puts a lens on the economically vulnerable and how that strategy needs to support the economically vulnerable so that the benefits are felt throughout the community. And it also reflects other opportunities such as the culture strategy that the council is developing. Domain 5 is around housing and the environment, and this is very clearly linked with the local plan, but also with the housing strategy and the homelessness strategy. We essentially want to reduce homelessness, improve the quality of housing, improve access to safe housing for those experiencing domestic abuse or violence. And the last item on the agenda was related to our previous discussion of Goal 5C. And then 5D is a broad goal around how we use the local plan to promote health. And then finally, Domain 6 is around community safety. This is very much linked to the community safety partnership priorities, and also to the Brighter Future strategy around enabling children to live safely in their communities. In summary, this is about reducing crime, reducing the fear of crime, and supporting those who are affected by crime, victims, survivors, and also those who experience the fear of crime. So that's a whistle-stop tour through the health and wellbeing strategy, just to give you the kind of breadth of what it includes. But I'll stop there for any comments.
Thank you, Joe. I think all new members especially appreciate running through that, just to make sure they've got overlying figures really of what we are trying to achieve here, the transformation and the integrated working and placing people at the heart of solutions really, and not just putting them in the middle of a service. It's actually what do we do to actually create a solution for working for each individual case, rather than just block putting people together. I did see Councillor Shinnick, you had your hand up.
Thank you for your brief. Make me go do so slide. Basically, how do you reach out to the general public to get all these statistics? You know, where do you go to get the statistics?
So we use a variety of sources to get the data that we use that underpin this strategy. So a lot of the data is nationally collected data. We use the data sets, for example, of ONS a lot. Not just in terms of the population, but they have data on all sorts of other health and wellbeing aspects. And we can break that down generally to Thurrock, then down to wards, and down to very small areas, lower super output areas that are areas of about 1,500 people. We can go down to that small level on a lot of our data, not all of it, but a lot of it. We also have data sets that we collect, for example, locally through our services that are delivered, and certainly when it comes to a lot of the statistics about how well services are delivering against their targets, that's where we get that data. And then the qualitative data, which is super important, we get through a variety of methods. So when we consulted on the health and wellbeing strategy, we used the consultation portal for the council, but as I said, we had Health Watch going out and about, speaking to people one-to-one and recording people's thoughts, and all that was pulled together into kind of a master spreadsheet and summarised for us. So we have a lot of data sources that we use, and a lot of them are standard national data sources, because that enables us to then compare with other areas and see how we're doing compared to our neighbours that are very similar to us, which is very helpful.
Seems like you do quite a lot of work getting all the data. Can I just ask one other question? My main thing I pick up from the general public is getting through to GP surgeries. I don't know if that comes into your domain. And I did see on 3B that they were going to upgrade these services. I didn't have a chance to read it all because it wasn't there long. But I just wondered if there's anything happening going forward regarding this, because for myself alone, it is a nightmare.
Margaret, I see you've got your hand up there.
Yes, thank you, Chair. Councillor, yes, there is a significant amount of work happening as we speak regarding a national imperative in terms of recovering access to primary care. And that covers telephony, it covers a whole range of things. And the 27 GP practices in Thurrock, along with every other GP practice in Mid and South Essex, has been evaluated in terms of the level and degree to which they are already accessible or not. We have a small group in Thurrock. I'm afraid I can't give you the actual number because it's one of my members of staff that's directly working on this. But we have a small number in Thurrock who are going to receive intensive support to improve and increase their accessibility. We then have a slightly broader group who will get an intermediate level of support, and then another smaller group who actually will only get a light touch because they're already doing really good things. And the point of that is not just to increase immediate accessibility for patients and all the residents in Thurrock, but actually to level up the accessibility across all the GP practices in Thurrock.
Right, thank you for that.
Thank you. Michelle.
Oh, thank you. I mean, it's on the theme of GPs, actually. One of the things that schools talk to me an awful lot about is parents saying that the access to a GP, and I've read in the report that actually Thurrock hasn't got enough, I mean, I think we know that, hasn't got enough GPs. I mean, I guess it feels like this has been a conversation that's been going on for a significant period of time. And I just wonder about the plan to address that. I mean, I recognise that it's not just GPs. We've got shortages across a whole range of specific specialisms, but just really around what the plan is to sort of try and address some of that.
Margaret.
Chair, would you like me to? Yeah, thank you, Chair. Yes, we have a GP fellowship scheme in Thurrock. We currently have one additional GP who is recruited and is based at the Pear Tree Surgery. By August, we will have 5 GPs in post. These are additional GPs. And there is a new Mid and South Essex wide fellowship programme, which is being spearheaded by the ICB's Chief Executive, Anthony McKeever. And that MSE-wide GP fellowship programme will run alongside and in parallel with the Thurrock GP fellowship programme, and we are anticipating that once that is up and running for real with GPs in the new fellowship programme, we will actually then draw more GPs into Thurrock. So as I mentioned, by August we will have 5 additional. And then throughout the remainder of this financial year, we are expecting that there will be more than that. The plan for Thurrock is to have at least 12 additional GPs.
No, thank you. I think it's slightly good news, I should say, to say that we've got 5 more additional GPs coming. I know conversations with the former portfolio holder numerous times asking about an update on what's happening to the 12 fellowship GPs. And good to see we've now got 1 in place, but knowing that there's 5 more on that programme is welcome news, to say the least, in a especially under-doctored area such as Thurrock. May I ask any other member have any other questions? Councillor Rigby.
Thank you, Chair, and thank you, Joe, for your report. So the strategies are obviously all excellent there, and it's a well laid out plan. It's just the sort of the delivery and the practicalities that are going to be the issue. As Kim brought up earlier about the sort of socio-economic aspects of being able to afford healthy fruit and vegetables. What sort of plans do you think can be done to sort of help that sort of area to tackle overall health and obesity, especially in children?
think having, come out of the pandemic and then obviously the national challenges of Brexit and the cost of living, and this is really being felt by our families. And so it affects a whole range of well-being for families and not just obesity. To consider the access to healthy food, though, there are a number of things that we're promoting. So, for example, Healthy Start vouchers are available to families with new babies and young children, and we're trying to promote those because there's a large proportion of people who are eligible for those that don't claim them. So they can be used to buy baby food and healthy foods for families that have very young children. So there's a number of initiatives that are out there that are not 100% being taken up at the moment. We're promoting those. We're also going to be working with the new family hubs that have been set up in the borough to take the kind of holistic approach to supporting families with the multiplicity of needs that they have when they have young children. So we will be building this sort of support into the range of support that is available through family hubs. The family hubs have a particular theme, and we've got national funding to focus on infant feeding. So we will be using that opportunity to both promote breastfeeding, but also look at infant feeding and nutrition for young children more generally as well, and also related things like oral health. So we have got a number of things in train, and there are opportunities that we need to get out so that our families are getting all the support that they're entitled to.
Did any other member have any questions on part one? Oh, Councillor Cynic.
You getting that information out, would it be a good idea if you sent that information out to councillors, then we could reach out to the general public we talk to? You know, it's just an idea. Thank you.
Yes, most definitely. We can, there's quite a few things actually we could share, I guess, through members' services, couldn't we? Yeah, I'll pick that up.
If all members are content with part one, do you want to move on to the second part and move on to looking at domain one in detail?
Yeah. Thank you, Chair. Darren, am I able to share my screen here? I'm in the meeting, yeah. Right, I think that might be easier then. Oh. Sorry, bear with me. Okay, so this is the second year of our health and wellbeing strategy. Last year we presented our plans for each of the domains in detail to the Health and Wellbeing Board, and then this year we will be looking at one domain at each meeting in more detail to advise the board on progress that has been made. It's worth noting that this responds to a review of the Health and Wellbeing Board that was done last year, where it was recommended that we strengthen the monitoring and oversight of the Health and Wellbeing strategy by the Health and Wellbeing Board. So we're going to, this is why we're giving more detail on each of the domains, to keep this a live document and to obviously get the board's ongoing input to the strategy as it's delivered, not just as it was developed initially. So as I said, domain one is about supporting people to remain healthier for longer. And this domain covers what might traditionally be thought of as a lot of the sort of traditional public health services. So we've talked a lot about obesity in this meeting already, so that falls under this domain, supporting people to stop smoking, but also broader health care and preventative work in healthcare, so to prevent people from getting ill, covering both physical illness and mental illness, including things like addiction. So that's what this domain focuses on, and you can see at the bottom we've got three goals within this domain: to reduce smoking and obesity in Thurrock, to work together to promote good mental health and reduce mental ill health, including addictions, which is a form of mental illness, And then the last one, to continue to enhance identification and management of long-term health conditions. And we say continue because we've been doing some excellent work on this over the past few years that I'll talk about in a moment. So the first one around smoking and obesity, we've talked quite a bit about this actually, so I won't repeat what we've already said. But what I will add around tobacco is that we are finalising a whole system tobacco control plan for Thurrock and planning to bring that back to the next meeting of this board. This was based on some detailed work that Public Health did to look at needs around tobacco using a lot of the data sources that we mentioned earlier. And there are essentially 3 strands to this. So prevention, stopping people taking up smoking in the first place and becoming addicted. So that's particularly targeting our young people. And there's a question around vaping around that as well. Treatment, which is supporting people who do smoke to stop smoking. So this is an adult-focused service. And then enforcement, which is about supply and restricting access to illegal tobacco, which can have additional health impacts over and above cigarettes. So we've started work on this already, even though that we're just finalising the plan. And in terms of supporting stopping smoking and reaching that target that you mentioned before, Councillor Rigby, we are now targeting our support to stop smoking much more than we have done in the past. When smoking rates were sort of, 20%, it made a lot of sense to just have a universal open access smoking cessation service. Now we still have that, a universal open access smoking cessation service, but we've also got a number of other approaches now. Firstly, we've got approaches that use medication to help, so nicotine replacement therapy to help people stop smoking. We have options that don't use medication because some people prefer that, and we're also have an option where people could switch to vaping. This is for adults with support to stop smoking. But we're also looking at groups that either have high need or high risk around smoking as well. So we know that over half of our smokers in Thurrock live in our 8 most deprived wards. So we're working very closely with GP practices in those wards and targeting work to those wards. We also know that smoking is higher in people who work in routine and manual occupations. So we're working with some of the big employers we have in Thurrock who employ people in those types of occupations. And we also know that smoking rates are extremely high in people with severe mental illness. It can be as high as 70% for some conditions. So we're also looking at how we can work with mental health services to support that group in particular. And then finally, working with maternity services, as it's a great opportunity to support women and their partners to quit at that point, because we know that 11% of our new mums are still smoking at the time of delivery in Thurrock, so there's a bit of work to do there. So we're doing a lot of work around that targeting of support. The whole system's obesity, I think we've talked quite a lot about that. I'm just thinking if there's anything that we haven't mentioned. I think the key point about this is, though, there's an awful lot of work going on, support to weight management in adults, support to weight management in children, but actually it's that whole system approach that Jeff mentioned that is really, really key here, because one intervention is not going to make the difference. It's how they add up, the multiplicity of support. So that whole system approach across all our partners is really, really key. So last year we set out some commitments for the health and wellbeing that we would deliver in year 1, and this slide just gives an update on those. So we've completed our joint strategic needs assessment for the local plan. In fact, we're presenting it as a health in all policies report around place shaping, and it identifies approaches that the local plan should be building in to address particularly things like obesity, but also other health related issues such as air quality, for example. So that includes things like the food environment, access to healthy food that we've talked about, but also things like how we can use the planning system to affect access to healthy food and unhealthy food, how we need to think about transport, for example. We don't have a lot of active travel infrastructure, so in many parts of the borough, walking and cycling can be quite difficult in Thurrock, so how we encourage people to move more in that way is all part of this report, and we'll feed that into the local plan. As I said, we've co-produced a whole system tobacco control strategy, and that will come back to the next meeting. And our whole system obesity strategy, when we wrote the health and wellbeing strategy, we thought that probably what we needed to do was review the whole obesity strategy. Actually, having done that, the current strategy that we have is still fit for purpose. What we need to do is amend the action plan. The strategy was written pre-COVID, and of course the world has changed enormously and the delivery environment has changed enormously. So a lot of the initiatives that we've spoken about today for obesity are things that have happened in the past couple of years, and particularly since the COVID pandemic. So we're targeting specific actions in that action plan to update them and make sure they're still fit for purpose. But the overall strategy actually is very robust and fit for purpose still. I've talked about reducing the proportion of people who smoke and the variation between community groups. The targeting that I've spoken about will help us deliver that, and so we have a lot of initiatives that are developing that are addressing that. And we've talked about obesity rates in children, how we have a specific service, but we need to take that broader approach, working with schools, with family hubs, etc., as we've already said. So at the bottom of this slide, we are setting out some commitments for year 2 under this goal. So first is implementing the tobacco control strategy, revised weight management pathways across both local authority and NHS services. We've talked a lot about these, and how, what I think the point here is that we've talked about a lot of different interventions, and it can be a bit fragmented. What we need to do is make it into a seamless offer that's easy for people to navigate. So that's what we'll be doing over the next year. I've talked about commissioning an enhanced children and families weight management service through our 0 to 19 service, and we will be feeding that health in all policies place shaping insight into the local plan. So that is how we'll be taking this forward over the next year. Goal 1B in Domain 1 is around promoting good mental health and reducing mental ill health, including substance misuse and addiction within our communities. So this goal very much spans the services provided by our NHS colleagues, but also work led by the local authority and also our police colleagues. So at the last Health and Wellbeing Board meeting, Public Health and the police gave a joint presentation on suicide prevention. So again, this is a very partnership and multi-agency approach that we are taking to this. The slides I've got here are slightly updated from the version that was sent round with the papers, but the commitments we made in year 1 last year under this goal were to complete a substance misuse health needs assessment. That has been completed, is now available on the council's website and has been circulated. I think it was the former membership of this committee that got it actually, so the new members won't have had it direct. But we are now taking the insight from that needs assessment into recommissioning our substance misuse services. So we will have a new service from April of next year, and we are looking at the service specification for that at the moment. Some of the issues that were identified as part of the health needs assessment, to give you an idea, are how that we need to strengthen dual diagnosis support for people who have addiction and other mental health problems, because the two are co-occurring in a large proportion of our substance misuse clients, and we need to strengthen that pathway. We also found that there is a large level of unmet need in the borough. Largely the people we support through our substance misuse services are people with more extreme and problematic substance misuse, where it is having knock-on effects into other areas of their lives. But there is a large level of unmet need that actually is quite hard to quantify, which probably makes sense given the nature of the issue. But we do know that there are certain groups that are particularly underrepresented in our services, such as some of our black and minority ethnic communities. So we want to, as part of the new service commissioning, work with the provider to take a human learning systems approach to increasing accessibility for some of these underserved communities. So we're building this individualised and personalised approach into our new commission service to try and address some of the issues that the needs assessment has found. We have in the past year launched a multidisciplinary complex care team pilot, and that includes both mental health, housing staff and substance misuse staff working in one single multidisciplinary team. And this, as I said, people who are engaged with substance misuse services are often also engaged with other services because they have a multiplicity of issues. And we really need to support people by looking at the individual rather than individual needs. So again, this is very much a human learning systems approach to addressing individuals' needs. And that pilot is ongoing. And we will be building, certainly from a substance misuse point of view, building being part of that service into our new commission service from April. The next two goals were around mental health, and I think this is where my comment around this is not a comprehensive overview of everything that's going on in mental health. There is a huge amount of activity that our NHS partners are leading to transform and improve mental health services. So, for example, the new urgent and emergency care centre where people with mental health crisis can go outside of A&E for a more appropriate place to receive care when they're in crisis. So there's a whole load of stuff that's happening in the NHS. But these were where, when we looked at the strategy, we thought, actually, if we get these things right, there are key inequalities that we can either prevent or address. So the first one is around the increase in common mental health disorders around anxiety and depression that we have seen across many groups in our community. And so we've put in place a new pathway for people who are newly diagnosed with depression. As you probably know, the medications that people take can take some time to start to have the optimum effect. So we've got support in place from Mind for people who have a new diagnosis in primary care. They can be referred to Mind, and Mind will get in touch with them, contact them to support them through what is probably quite a difficult time in the start of their treatment journey. So that is in place, and we will be doing some evaluation later in the year to assess the impact. The second area around mental health, where we thought there was a particular vulnerability and risk of worsening inequalities, was around young people who have mental health issues and that transition into adult services. And we have, this is a vulnerable point for all young people who need to transition into adult services for a whole range of things, from social care, physical health needs, as well as mental health. But in terms of mental health, they can be particularly vulnerable at this time. So there is a service, a very detailed and comprehensive service transition policy in place, and the mental health operational group have oversight of this. We are looking at putting in a longer term commissioning resource to make sure that this is supported, and the service providers assure us that the policy is being implemented. The one thing I haven't got that I wanted to share with you today is some idea of quantification of how many young people are transitioning, and an absolute assurance that 100% of them have these plans in place, and I will continue to chase those numbers down. So our commitments under this goal for year 2 are to complete our recommissioning of our substance misuse service. It will be a new integrated all-age service, and we will build in addressing some of these gaps that we've had in service before that I've already mentioned. We will commission the complex care team with an assertive outreach for substance misuse on an ongoing basis, and we will do some work to enhance the dual diagnosis pathway for substance misuse and mental health. We've started some work on a case-finding strategy that I'll say a little bit more about in a moment, but it's about finding and diagnosing individuals who have new conditions for either physical health or mental health conditions. And mental health diagnoses in people with cardiovascular conditions is one thing we're going to specifically focus on in the next year, because often physical and mental health conditions are co-occurring for many people. and we will evaluate the wellbeing calls for people for new depression diagnoses. So those are our plans for the next year. And then finally, Goal 1C is about improving the management of long-term health conditions across both physical and mental health conditions. We've actually been working on this jointly between primary care and public health for a number of years now. And I recently gave a presentation to the National Clinical Leads Group for Cardiovascular Disease, because the impact of the several years of work that we have done means that Thurrock now has the best quality of care for cardiovascular disease in the country, despite what we've said earlier about being significantly underdoctored in terms of GPs. So we've done some really targeted improvement work that is really now starting to pay dividends for our long-term conditions care. The reason we're focusing on these long-term physical health conditions is because they're key drivers of that inequality in life expectancy that I talked about earlier. Cardiovascular disease is the #1 clinical condition that drives that gap. So closing the gap in cardiovascular disease care is really, really important. So in terms of the commitments we made last year, we have implemented health outreach sessions for both our traveller and showmen communities, and that's across all the traveller sites in Thurrock. We now have a programme of visits that's supported by public health, by the traveller liaison officers and by NHS colleagues from across the system. And we are starting, in the coming year, we will be doing outreach with the soup kitchen and support around homelessness. Rita's already mentioned the IMWC in Corringham, and that was one of our commitments under this goal for this year. So that is now in place and hosting a whole range of multidisciplinary health and wellbeing services, which is excellent. We were going to improve the quality of care for long-term conditions, and as I mentioned, we've done a huge amount of work with primary care on this in particular. We're continuing this year. We were focusing on the gap in quality of care in previous years, so people who should have been getting a level of care and weren't. We've closed that gap now, so many more people are getting the high quality care that they should be getting in primary care. And we're now looking at taking a longer term preventative approach, so people with lower risk cardiovascular disease, how we can support them in a similar holistic way to the way that was mentioned around the Healthy Futures Clinic, supporting them not just to look at a single disease, but to look at the individual through a human learning systems lens about what will support them to remain as healthy as possible. And that's how we're going to manage to reduce health emergencies in the future. So that is in place and will be running through the rest of the year. And we're also working with our ICS colleagues about how we can spread some of the learning from Thurrock on this across the rest of Mid and South Essex, which is really exciting. We said we would increase the proportion of people who have their long-term conditions diagnosed and treated. And we've monitored hypertension in particular, and hypertension diagnosis rates have increased year on year for the past 4 or 5 years in Thurrock. Despite the COVID pandemic, that diagnosis rate has continued to increase. So I think that's a real tribute to our primary care colleagues there. And we will continue to do this through our case finding strategy, which is one of our commitments for this year. And the final commitment was an increase in the percentage of individuals with severe mental illness receiving a physical health check. So around 4 or 5 years ago, this was only 17% that were getting this health check. In the most recent data, it's up to 61%, which is a real increase again from where we were. We'll be doing some more work on not just delivering the health checks, but also following up on the issues that are found in those health checks. Because what we're doing the work to look at this, we've realised that those follow-up referrals are not always happening. But we have got a high proportion of the checks actually happening. So our commitments for the coming year are to continue the outreach programme for our traveller and showmen communities and initiate that homeless soup kitchen outreach and to do some impact evaluation of that. I mentioned the case finding strategy. This is a big initiative for us in public health and primary care over the next year because we've done so much work at improving the quality of primary care for long-term conditions that the biggest impact we'll have now on population health is by increasing the number of diagnoses. So we want to get more people diagnosed and having that high quality care that they should be getting. So this will focus on cardiovascular disease initially, and then we will look to roll out to other conditions, but we will have a particular mental health strand as well, as I mentioned earlier. The MSc ICS Population Health Improvement Board, we will work with them to support health inequalities initiatives across Mid and South Essex. And I mentioned that our cardiovascular disease approach is one that we're already discussing with that group in Mid and South Essex. So we want to start to share the learning that we've had. And we will, as I said, deliver an action plan for SMI health checks, which includes not just increasing uptake, but also following up on diagnosable issues. And I'll stop there, Chair. The final slide is just some metrics that we have. It's very small. I won't go through the numbers, but we are monitoring some key metrics, and we will do that over the next 4 years for the strategy for this domain. Thanks.
Brilliant. Thank you, Chair. Does any member have any comment straight away? We've had Ian, do you want me to come to you?
I just wanted to touch on the last point, because Joe's being a little modest, and I really want to pay tribute to Joe, to the public health team, and to colleagues in primary care. So a couple of months ago, I was contacted by Dr. Shahid Ahmed, who's the national clinical lead for cardiovascular disease. And he contacted me because he said, I've just run the data, and your subpopulation system in Thurrock has the third highest level of completeness of hypertension registers. What that means is of the total population of people with high blood pressure, Thurrock is the third best in the country for actually finding and diagnosing and treating them. And you've got the best control of cardiovascular disease when diagnosed in the country. And it just shows you that is, if colleagues around the table don't believe that partnership working has an impact, that is a direct result of what the Health and Wellbeing Board and the Integrated Care Alliance set out to do back in 2017. And when you have a concentrated effort of a range of programs as we put in place across partners working together, that is the impact that you have. You can see, and I received the data actually this week from the public health team, that translating actually into a drop in hospital admissions for cardiovascular disease, the biggest killer in Thurrock, the greatest cause of immediate health inequalities. And I think that's actually quite astonishing, given our level of deprivation and given our level of underdoctoring. That equates to hundreds of lives saved, thousands of people who haven't had strokes and heart attacks and maybe would have been incredibly disabled and have a very poor quality of life as a result. It's a programme embedded within our Better Care Fund, and I think it's just worth reflecting on the success, and it is everyone around this table and in this meeting, in terms of our colleagues in the ICB and in the former CCG, our frontline providers in the NHS, the third sector who've been absolutely involved in terms of embedding community diagnosis of hypertension, Health Watch, who have undertaken a lot of the initial engagement to get us to that point. I think it's just really worth recognising and celebrating.
Definitely, thank you, and I echo near enough every point you've made. It's when we talk about exactly what we're trying to do in the long run in terms of transformation, this is the fact that we're proving a point, we're becoming a case study to show this works, even with all the limitations that we have, that we can achieve these goals, and it works better not by siloing people away, but integrating together and working towards that common goal. And the proof now of where we are, the best in the country is, and even some of the best in some areas, is exactly what we need to go. And it's something that we really need to be shouting from the rooftops about. And perhaps modesty is not the best one on this one. We need to be proud of it, and we need to show pride in that. Definitely. Councillor Shinnick, I know you had your hand up.
Oh, thank you, Joe, for your report. It's really good. One of my main concerns in the borough is substance misuse, because wherever you go, you see the little canisters, but now they've gone on to the bigger canisters, you know, for inhaling things through balloons. And I didn't know, is there any way you can reach out to schools and go and talk to the children, you know, and tell them of the dangers of this, you know?
So part of our commission service for substance misuse is very much around education and outreach. And that's an absolutely key part of it. In fact, all our, I would say, main commissioned public health services have an element of outreach into schools, whether that's about sexual health, substance misuse, mental health. So yes, that is very much part of the approach to reduce harm through that intervention early.
Jeff, no, you had your hand up, then Councillor Rigby afterwards.
Thank you, Chair. I can't add much to Ian's point, which is to acknowledge the excellent work that's happening here in the borough, and thank you, Joe, and the team for those successes you've got. As you know, Chair, I'm committed to making sure that we recognise and acknowledge the successes here in Thurrock and make sure that we're able to share those across Mid and South Essex to ensure that the learning that you've achieved here is replicated elsewhere. A couple of really practical points, if I may, Chair. Firstly, just to say, as we mentioned earlier, risk thrives in gaps. And the reason that we want to do better integrated working between services is not only because it's more effective and it's more efficient economically, but also because it mitigates risk. And particularly in relation to the work on mental health and children and young people, Joe, you mentioned about the challenges of transition, and we're really clear that multi-agency differentiated all-age approaches to mental health is absolutely imperative to make sure that we eliminate the risk that occurs when people transition from one type of service to another, and we're really supportive of the work that's happening there. Another really practical point, if I may as well, is just in relation to the obesity issue, which is of concern to this meeting today. It's perhaps worth just noting that the World Health Organization in their 2019 report recognised that children who are breastfed as babies are up to 25% less likely to experience obesity in their childhood and as adults. The research is very compelling, actually. And so I just wanted to, again, in that multi-agency working, recognise that across South Essex, there is a growing movement of volunteer breastfeeding support groups, particularly in Basildon and Thurrock, the BRAS group, who are accredited breastfeeding supporters, accredited through the Institute of Breastfeeding Mothers and others, for example, World Health Organization accreditation. And I think leaning into those groups who are out there working with communities supporting breastfeeding would be a really positive initiative in terms of supporting it, because if we can tackle it early through support, not only through our maternity and health visiting teams, who obviously are there to support mothers with breastfeeding when their children are born, but actually throughout the journey, and to ensure that we're leaning into our voluntary community sector partners in that kind of growing movement across South Essex would be really positive.
Councillor Rigby, before I jump over, Joe's got a few more points to add to that. Do you mind if I bring her in there?
Thanks. I just wanted to follow up on Jeff's very well-made points and just reassure the committee that the family hubs development work that is going on at the moment is very much taking that approach. So our infant feeding strand is working with professional services, but also particularly the BRAS group. We want to bring in voluntary sector support, and we have particular funding around breastfeeding peer supporters that we want to bring into the model. So we are, doing exactly that.
Oh, Councillor Rigby.
Thank you, Chair, and thank you, Joe, for your report and all your hard work. So as Ian was saying, it's brilliant news on the hypertension diagnosis. I don't know if it's across all GP surgeries, but I get a text message every few years inviting me in to check my blood pressure. So that might be a part of how it's sort of being achieved. Are there any other areas that sort of a similar messaging technique or target could be introduced, do you think, to achieve such high levels of diagnosis?
Absolutely. I think we've proved that the approach works now. And so there's a whole range of long-term health conditions that we can start to take this approach with. In fact, the way we've developed the primary care service this year is to identify people who've got cardiovascular disease and one or two other diseases, and then look to offer a holistic review of all of their conditions together and how they interact. So absolutely, so it's about looking at not just individual conditions now. I think it's about the multiplicity of ways in which we can use this holistic approach to support people, but certainly respiratory conditions, diabetes, and also often co-occurring mental health conditions. I think we need to be very much focusing on that cohorts. Yeah, definitely.
Does any other member have any questions or comments? No? Well, in that case, thank you, Joe, for the report and the update on Domain 1. As you say, we're trying to keep the board's part of the vision is to make sure we're on top of this document. It's a live document and we're constantly feeding back. So every meeting we'll go back to link back to one of the domains and we look in a bit more in detail. And I think it's a really great way of doing it and making sure we are staying on top and actually delivering on this strategy. In that regard then, I'll move to the recommendations to say that the committee has noted the overview provided, the complete health and wellbeing strategy, and we've provided a review and comment on and approve the progress that's been made against Domain 1 commitments and previously approved by the board and commitments for Year 2. All members content?
Agreed.
Agreed. Thank you very much. And that brings us to the end of business, and I can close the meeting at 12:22. Thank you.
Very well chaired.